So thank you to all of the presenters. It's a really incredible scope of different presentations. We have a couple of minutes for questions, and there are 2 mics. If anyone has a question, if you wouldn't mind going up to the mics. You can say, and I can repeat it for you.
Can everyone hear? Yes.
I'll repeat it for you, yeah.
So it may be just like a really simple question, but I just had a question while I was sitting here. So why do you think preferences are so prevalent within an already marginalized community, and what effects could you see it having on POC's mental health and relationship building?
So the question was around why do you see these preferences existing for marginalized communities, and what kind of effects they would have on mental health and relationship building? Was that for people of color? Was that for any specific person?
Just for general question.
Anyone who wants to respond?
Yeah, I don't mind responding. I'd love to respond. So your first question was, or the first half of your question was really about why we're seeing these disproportionate rates of new HIV diagnoses, and the second part was like, how will this affect folks' mental health? So I think that like right now we're talking about groups that are already marginalized within society. So we're talking about groups that already experience, within the context of mine and David's presentation, it's really about Black folks. So within the context of groups that are experiencing anti-Black racism, this is the health outcome, right, within the context of HIV. If it wasn't HIV, it would have been something else. So if we push groups to the margins of society in terms of their ability to socially and economically participate, to feel like they belong in a society, we are going to see negative health outcomes for those groups. So it's not purely about the physical risks of transmission of HIV, but it has equally to do with the social determinants of health. And then just getting to your second point about like the mental health of these Canadians. So there's a lot of like really revolutionary, groundbreaking work being done in Canada to address mental health needs, the specific cultural mental health needs of Black Canadians. So just participating in that work and understanding that we can see outcomes tangibly through these health disparities, but we can also see it through things that might not be so visible. So dealing with everyday racism is really tiring. So we have to make sure that we are developing a mental health sector that has folks that are able and equipped to deal with mental health issues in specific communities.
When I was appointed twice by President Obama to the U.S.'s Presidential Advisory Council on HIV and AIDS, one of the things in which that we consistently heard and what we brought forward is that HIV and AIDS exposes the many inequities within society. And so it's not by accident that the marginalized, those people that are voiceless and or powerless or pushed to the fringes, is where you will actually expose that, those inequities, and those inequities of accessing health care, or even how we show up and our well-being, and whether or not we think that we deserve quality health care. And so it is both an internal as well as external pressures, or how we look as racialized minorities and or other minorities. This is not just. We look at, like, at the beginning of this epidemic, how this impacted the white gay men. And it is whether or not we deserve or whether or not we want to participate. So we're responding, and it's both external and internal, and it becomes a mental health issues. And so it is looking at the myriad of social, economic, and political inequities, and that is where we must focus our attention if we want to address this disease and or many other social determinants of health.
I'll just, I think we have time for one more question.
I'm wondering, across the panel, I'm a volunteer coming up on 15 years at an agency that was formerly an AIDS service organization in Victoria. And I started as a reception volunteer, became a board member, became the public spokesperson, became board chair, and I'm now back still as a reception volunteer. And I'm wondering if there's any research being undertaken or anecdotal impressions of the impact on what used to be AIDS service organizations, and in a community as small as Victoria, somewhat a gathering place for a segment of the MSM population. The transition from an epidemic that has its roots in the 20th century to a newer epidemic, certainly here on the West Coast and throughout the country, in fact, probably the world, the overdose and substance use due to mental health challenges that people are living. I'm seeing an agency that used to be called AIDS Vancouver Island, which has had to rebrand itself as AVI Health Center, and I'm not sure it even deserves the A in AVI any longer in terms of provision of services. And as an HIV positive gay man, I don't actually feel very comfortable in my agency, and I have been stigmatized in ways that, 15 years ago were not happening. I'm wondering if anyone has thoughts on that. Thank you.
Ooh, there's like a lot there with that comment. Oh my gosh, I'll try and do it some justice. I think there are a number of complex reasons or factors at play that are impacting gay bi queer men's relationships to ASOs, particularly in Ontario. Certainly the organizations that we work with in the province are overwhelmed and under-resourced as it relates to the opioid crisis, which does impact gay bi queer men in our community. And I think there's actually a session tomorrow on that, which I'm really looking forward to, because I think gay men have been largely invisible in that response to the overdose crisis. But with the sort of some of the challenges experienced by certain ASOs, we've also seen the emergence of new organizations like MAX, grassroots organizations that have emerged across the country that are really centering the experiences of gay bi queer men and the development of their programs and services. And so I think it varies, but there are, at the same time there's challenges, there's also a lot of great opportunities. And I'd be curious what other folks' perspectives are.
I believe that within my last response is that that this disease happens, as well as our health and how we dwell, is that we just don't become little compartmentalized. Like this happens within social, economic, political, spiritual realms of how this impacts us, right? And I think, and then you add in the many diversities that you see represented at this table, racial, which is social, and that this disease, and specifically around HIV and AIDS, that we have to look at, and you look at the models of syndemics, or we're looking at social determinants of health, that we have to expand this conversation if we want to end this epidemic. And as a result of that, when this disease started, and I think that Robin DiAngelo talks about this in White Fragility, right? There was this push for it being all-inclusive, or there was this like underlying pinning of that it was objective, and this objectivity or this universality. And when we don't name it, what that does is it defaults and it positions white, heterosexual males. And for many, many years, it worked under that objectivity. We're talking to everyone, and we don't want to like single out people. And what the default was in the coding that Robin points out is that was for white folks. And now there is a decentering of that, and where we're seeing that black, brown, and other racialized minorities, we are disproportionately impacted by this disease, and we must start focusing and centering that intent. And what you hear is this research panel is that we are centering those folks. And it shouldn't be a them and us. It is just different stories, different narratives, different priorities, and we're not competing. It is just that we must focus that if we want to make an impact on this, but more importantly, looking at the health and well-being of those various bodies and the beauty and the diversity that exists. Lastly is, thank you so much, one, for the question, but even more, a statement of gratitude that I would wish to honor, witness, and acknowledge is your volunteerism. I believe that we are all volunteers within this room. You heard from our bios, and it is through our volunteer and our civic engagement is that we are addressing and we are actually addressing this disease. And it is done, and so I hear your recommendation, hire and to pay, but also to engage and to lean in. And so I look at the work that we did with the 2018 Sex Now data. It was important that the survey instrument, we saw ourselves within that survey instrument. Secondly, who was doing the recruitment? I know that I myself recruited in full regalia. 90% of the people who I went to and said, do you want to participate in the survey? My community, they said no. And what I had to say, come up with a 15-second respondent. So I was like, that's cool, you don't have to participate in the survey, but can I ask a question? If only gay white men participate in the survey, guess what happens? And they realized that it was bigger, and I never had to answer the question. So who's doing the recruitment and how that recruitment is done? And much to the credit of Nate and the team of CBRC is their commitment. And although Indigenous people only make up less than 5% of the general population, because colonization has been incredibly effective, in the sample size of the in-person 2018 survey sample, 9% participation. If CBRC can do this, we all can do this. And it shouldn't just be us. You and the research is that we should be embedded. And it is a commitment to our community. And we should be all looking at standing in community as one. But that also is an honoring and a celebration and a lifting up of the diversity and the beauty of what we would heard at the keynote of that rainbow grandmother. And so I just want to say that CBRC has done an amazing job, but it shouldn't be the outlier. It should be, and it's a clarion call, if they can do it, we all can do it. But how they did it is where we should be turning our attention. And it is something that we should be doing as good researchers, good scholars, good members of representatives of ASOs and other folks doing this work. So I lift my hands in gratitude to the representatives of CBRC, and that we have this incredible amount of research that we cannot wait to dig into so that we can do better work for my Two-Spirit community.
Thank you, Harlan. So I'm going to call this session to a close. I apologize for running over. Time is a social construct. And lunch is being served now, and you can just check your programs for whatever the next session is. Oh, it's a plenary, I think. Enjoy lunch.
Thank you so much. Thank you. Harlan, thank you, Gift from CBRC.